Welcome to Roundtable Talk, a podcast about longevity, senior services marketing, and the quality of life as one ages. Roundtable Talk is brought to you by Pavone Group and Varsity, a senior services agency focused on helping clients win the mature market. If you like the fresh perspectives we deliver in each episode, please give Roundtable Talk a 5-star review on the podcast service of your choice.
Hello, everyone, and welcome to another episode of Varsity's Roundtable Talk. Today, we're honored to have a truly distinguished guest joining us, Dr. Robyn Stone, a leading authority on aging and long-term care policy. Dr. Stone is the Senior Vice President of Research at LeadingAge and the Co-Director of the LeadingAge LTSS Center. LTSS stands for Long-Term Services and Supports. Under her leadership, the LTSS Center is bridging policy, practice, and research to advance high-quality services for older adults. Dr. Stone, thanks so much for joining us.
Great to be here.
And, as I know we reconnected at LeadingAge Washington a couple months back, but we met a few years ago when I was doing work with one of our clients in the DC market, and you were on their board at Ingleside. And, so that was a great way to get to know you and certainly understand the work that you're doing. Can you tell us about the journey into aging and long-term care policy? What drew you to this field?
Sure. It's interesting. I have a very close relationship, had a very close relationship with my father's parents. It's a typical story of having a great relationship with grandparents, but because my father died when he was very young and my sister and I were very young, my mother was a single mom and we basically were partially raised by my grandparents, and just an incredible relationship with both of them, very different. My grandfather was really very lithe and crazy and did all kinds of nutty things. And my grandmother was sort of the more stable, together person, you would say, but they were both fantastic. And so I loved older people from being very, very young. And that always attracted me to working in the field of aging and working with older adults. And quite honestly, my entire career has been in the same area in very different kinds of jobs, which I think is really important in terms of professional development. But every single job that I have had as an adult, starting with running a small meals program in Baltimore, working at AARP in the mid-1970s, all the way through my career now at LeadingAge, and all of my education, particularly from master's onward, really focused on older adults. And it's just been a passion of mine, particularly lower income older adults. I've been very interested in the equity issues around making sure that everybody has access to services and support so they can live out their lives in dignity and good quality of life.
That's wonderful. And you mentioned that you've been working in aging services your whole career. Now, I heard you speak at a LeadingAge Maryland conference a few years back, and you described senior living as an accidental career, a career that people don't often seek out, but when they land on it, they love it. And that has really resonated with me over the years. And quite frankly, I would say that's probably, I would fall into that category. I absolutely love working in aging services, but it wasn't something that I necessarily sought out. Talk a little about that. And
Sure.
Please go ahead.
I'm actually an exception because, as I said, I pretty much knew early on. I mean, it wasn't like I got up became 6 years old and said, boy, I want to work with older adults. But it was always in the back of my mind that I was interested in helping professions and that this was a population that I wasn't afraid of, that I loved, emulated, recognized how important they were. But I think over the years, and I have sort of I think of my career as a bimodal distribution. So the first 25 years were really focused mostly on policy, that kind of work mostly in Washington, D.C. The last 25 years have really been at LeadingAge at a provider association, working on applied research, but with a real boots on the ground perspective. So I've had the 30,000 foot and the boots on the ground perspective. And what I found, no matter where I went, whether it was a policy job or it was a on the job, boots on the ground job, that most people fell into these occupations, and once they started working in them, they discovered that they loved them. And one of my foci for almost my entire career has really been trying to shift that from an accidental profession to one where it becomes the norm. And I think we've made some strides, but certainly we still struggle. If you look at the challenges we have right now in recruiting, for example, nurses, social workers, even people who want to work in geriatrics on the clinical side, it is really difficult to get people attracted. Some of that may be that it's undervalued and not paid as much as other occupations, but it also, I think, has to do with some fundamental ageism in this country. So while I think we've made some strides, and certainly the whole field of gerontology has grown since I started in that work in the early 70s, we still have a long way to go.
No, that's great perspective. Thank you. Now, like I mentioned in your intro, you're the co-director of the LeadingAge LTSS Center, which focuses on advancing quality, educating consumers, building a strong workforce, and creating affordable housing for seniors, which you already had mentioned was a passion of yours. Now, the LTSS Center works to bridge policy, practice, and research, three very important things. How challenging is it to bridge these three things?
It is very challenging, and because I think I've had some fairly unique situations that have positioned me well. I was trained I started out as a policy person, was trained in my master's program around aging health policy, and then went to work in the federal government as in the first class of the Presidential Management Internship Program in Washington under Jimmy Carter. So when he died last week, I just revered him very, very much, and partly because he encouraged people to go into the civil service and to actually believe in public service, which I did. So I started in policy, then went back to get my doctorate in public health at UC Berkeley, and started to do research, everything from quantitative, qualitative, and as much applied research as I could, because I believe that you want to be able to translate what you're finding into real world efforts. And then when I came to LeadingAge and asked to set up an applied research group, it was really clear that this nexus between research, policy, and practice is an aspiration. You never fully get there, but what you're trying to do is to help to create evidence-based work, and then disseminate and share it with both the policy world so that they can have better policies that will actually help with real world change, and then work with also real world organizations to actually help them implement on the ground. And it is, as I said, it's aspirational, and it's also a journey. But I think it's critically important because information is key to actually making good decisions and having better outcomes.
That's great. Well said. Now, what are the biggest gaps in educating consumers about long-term services, and how is the LTSS Center addressing them?
Yeah, I mean, there's so much continued misunderstanding about what long-term care and what long-term services and supports are, because of the challenges of people who present with long-term care needs, which are really functional and focus on being able to live as independently as possible for as long as possible in the community and in various settings. So it's a functional approach, and it butts up with medical care because people who have functional problems and challenges also have a lot of underlying chronic conditions, acute exacerbations, post-acute care needs. So it's the whole gestalt of the individual. So if you are working with a long-term care population, these are typically also people who have a lot of other things going on. And that intersection of long-term care or long-term services and supports with the other parts, including, by the way, housing, which is critical, because if you don't have shelter that is adapted and amenable to your moving around, it's really hard for you to have mobility and to function well. And if you're cognitively impaired, on top of that, you have even more issues. So it's really that intersection. And most people do not understand that, nor do they understand what pays for what. So after, 50 years of working in this, we still have most people who think that Medicare covers long-term care. That's just one example of trying to educate people around what it is, what do you need, who do you go to, how do you think about paying for this, and so it's and the holy grail of somehow having people save for their own needs is a mantra that we've had forever, and we're not a huge saving society, so it is always difficult. As much as you educate, most people address long-term care needs when they're in a crisis. And so I'd say there's a combination of educating people about thinking about it beforehand, but also educating people about what to do when you are in the face of these needs.
That's a great point. And you're right. I think sometimes people feel like they're saving, but they don't understand really what it will take to pay for everything that you have to pay for, housing and care and things, leisure enjoyment and that sort of thing. Now, I'd like to talk about workforce development, which is a critical area of focus for the LTSS Center.
Mm-hmm.
The staffing crisis in aging services, and you referenced it earlier, has reached a critical point. From your perspective, what are the root causes of this crisis and why has it persisted for so long?
Yeah. It's interesting. I wrote a paper a number of years ago called The Triple Stool of Long-Term Care. And one leg was financing, another leg was delivery, and the third leg was workforce. And that is the leg that for so long has really been almost ignored and would only be addressed when there was some kind of a worker shortage or some kind of a crisis. And it's interesting to me because this sector is one of the most labor intensive of any sectors in the job market, and probably will remain that way, although we'll have to see what AI does around robotics and changing some of those things. But very hands-on work, but very undervalued, staffed primarily by a direct care workforce that is also undervalued, high proportion of people of color, high proportion of immigrants. This has been the way it has been for many, many years. And the long-term care sector, unlike the medical care sector, it's often considered part of healthcare, but I actually try to tell people that it really is different, again, because it's the intersection of services and supports to help people live and function independently for as long as possible. And those services and supports are interconnected with where people live. So it's the living and the services and supports coming together, very different from healthcare, hospitals in particular, where people don't live in a hospital, but people do live in long-term care, whether they're in their home and they're living in a nursing home or assisted living. So, this intersection makes long-term care very unique, but it's also been a real challenge to get the kind of investment that you need in it, and particularly on the workforce side. So COVID unleashed, I think, or lifted the veil on this essential workforce, which is 60 to 80% of all the hands-on care is done by this front line. Very flat workforce. So the rest of the workforce is some professionals who are in the job, and then you have all the ancillary folks who are working maintenance and service maintenance work, dietary. But the heavy lift is this direct care workforce. And I believe very strongly that there's two things going on. One is pervasive ageism, that forever people don't want to work in this sector, which is why I call this the accidental set of professions. But also there has been structural racism, I believe, in the sector, not necessarily intentionally by providers or anyone, but how the whole system has been set up. These jobs have been undervalued, underpaid, under-recognized in terms of the competencies that are required. And that then has a spillover effect on the entire workforce, including nurses getting paid less, social workers getting paid less, administrators getting paid less than they would in other parts of the healthcare sector, for example. So it sort of feeds on itself. And so we continue to have a history, not to mention the fact that Medicaid is the major public provider, which is a welfare program, right? So it has this whole perspective of undervalue. And I think that's one of the challenges with the workforce, that we've never been able to move it. Hope springs eternal that COVID turned a different leaf, and that we understand that if we don't invest in people, we are not going to get to the quality outcomes that we talk about.
Sure. Now, sticking with workforce for a moment, high turnover is a significant issue in aging services. What specific strategies do you believe are most effective for retaining workers?
I'm glad that you asked that question, Derek, because I just was with a reporter yesterday who was asking me a lot of questions about recruitment. And I answered that the best recruitment strategy is to retain, because the more that you retain your staff, the less you have to recruit. And retention is all about creating a culture of a healthy workplace where there is an investment, both monetary and non-monetary investment in that workforce. Certainly, we know that money matters, and increasing wages and other kinds of compensation are critical. When we still have 40% of this workforce that is on some type of public assistance, that's a travesty. We've gotten the median wage up now to about $17 an hour on average in nursing homes, and about $15 something on average in home care. But competitively, that's not enough. And with inflation, you lose what you gained. So it's a systemic problem of thinking about how do you strengthen the compensation side, but at the same time have a workplace where people are well trained and that they have great in-service, where they have a healthy work environment with really strong coaching supervisors, which is critical, the supervisory piece of this, because remember, it's mostly frontline with a handful of supervisors. So that supervisor piece is critical in terms of being able to empower and build staff into teams to actually do work and be recognized. And then finally, having career pathways. And not just necessarily that every aide wants to become an RN, but more that aides might be interested in specialties, geriatric specialty, mental health, behavioral health, medication. So there's a lot of focus in the high-performing organizations of looking at ways to build in career pathways for individuals who want that, also recognizing that the profession itself is valued. And that's where we really see effects on turnover rates.
That's a great point. And I've led a number of groups with frontline team members at communities across the country. And so frequently, with some regularity, I hear that people left the organization, a nonprofit, went to another, whether it was a hospital or another environment. And even though they were not paid as much in the not-for-profit environment, long-term care,
They went back.
They came back because they loved it. It's the mission. It's all of the intangibles.
Yes, we have found, we have interviewed thousands of staff over the years, and we have found people who said literally that they moved to a hospital for a dollar or two more an hour and came back because the environment was just so important in terms of allowing them to be professional. And I think we cannot underestimate that. It is all about value and all about a healthy workplace.
Yep. Well said. Now, you alluded to this earlier, but technology is often cited as a way to alleviate staffing shortages, things like robotics, telehealth, etc. Do you see technology having a meaningful impact yet?
I quite honestly, I don't see technology as having a meaningful impact yet, particularly with the front line. I think where technology has been impactful has been around things like making much more information much more easily accessible through electronic health records and trying to digitize that information on the long-term care side as well, even though I think we have a lot of interoperability problems. The challenge is that with a lot of organizations, there's a heavy focus on technology, whether it's digitizing the whole system, putting in sensors in people's rooms, using technology for better communication with residents and clients. But it doesn't get in the hands of the folks who do most of the work. And my recommendation has been when you're thinking about technology, start by asking what is your question that you're trying to solve. And I do think there is a lot of room for technological advances in workforce development and in creating more efficiencies so that the hands-on work can get done where the other kinds of work does not necessarily have to be done. The area that we've seen most progress in is in dining, where we actually see robotics and opportunities for efficiency so that the dietary staff can actually spend their time with folks who actually need help with eating or understanding their nutritional needs and not just passing out plates and things like that. So, but that is an intentional way of thinking about how technology works with the workforce. And I think if we had more work done around that, we would see a faster infusion of technology that really helps in the workplace space. I think in the workforce space, I think it hasn't gone as far as it could because I think we haven't thought intentionally enough about what's the complementarity of these two things.
It's interesting. It sparked something for me. As you're talking about robotics, I think oftentimes people think of it as cost saving and replacing employees. But the way you've described it is a really important insight, I think, where it can help the employees or team members be more effective. And I know, again, in talking with frontline team members across the country, people are stressed because they know they have to get their job done. They have to keep moving. But
Mm-hmm.
so much of it is about that personal relationship and connecting
Mm-hmm.
with the residents and making sure that they are doing well, not just receiving the services that they need to receive.
That's exactly right. I mean, I think another example of great potential for technology is in the PDA space. Um, the personal devices, your phones, where many places would want staff to leave their phones at the door, and this for young staff is like cutting their arm off. And I say, let's use those technologies, but let's build data platforms so that the front line can be entering information, changes in condition, things that they might see that get filtered into care planning and then turn around and make improvement. It's a win-win for everybody. The aides get to use their tools. They actually have information that brings them in as part of a team and they see the effects of it. So there is some of that going on, but not enough. This is everybody has a phone these days. And so let's take advantage of it. I mean, I think there's a lot of technology that could be deployed in different ways that would actually facilitate a more efficient and a more empowered and happier workforce as well.
Great points. Now, I did want to ask about compensation. One other point about that. It's often mentioned as a barrier to recruitment and retention. We've already discussed that a bit. But what policies or programs are you seeing that could help increase wages for these team members?
Yeah. Well, certainly we saw with the influx of ARPA funds, the American Rescue Plan dollars that came in from the federal government to states and to their Medicaid programs during and right after COVID, there was an influx of dollars that actually spearheaded states to invest in workforce policies. And this is the first time that we saw writ large across all of the states a really significant investment in workforce development, including looking at Medicaid rates, trying to figure out how those rates could be increased so that and how those dollars, those increases could be ensured that at least a good portion of them were passed through and passed on to frontline staff. So, and that I think has continued even after these dollars have started to dry up, because these were not dollars forever. These were temporary investments, but it jump started work in that area. There's also a lot of advocacy around improving the wages and compensation for this workforce, including looking at minimum wages in a different way. State minimum wages vary tremendously. How do we get that up? And we've seen a lot more change at the state level. And at the same time, really good high performing organizations have looked at their wage scales and have increased their wages as well and their compensation. I'm on the board of another organization that actually just started offering pet insurance, and not as a full benefit, but as a discounted benefit as part of a large insurance pool. And it's an attempt to think creatively about what kinds of insurance do various generations of this workforce need? What are they going to want? How are they going to use it? How's this a tool not only for recruitment, but also for retention? So I think it's not just the money itself, but it's also thinking about benefit structures, and how to use their resources more wisely within constrained dollars, at the same time that we have states at least looking at Medicaid reimbursement in a new way. So those are some of the things that I see happening. Of course, we've also got a lot of things like sign-on bonuses and all of that, but I think those are short-term fixes. The things that I'm talking about are hopefully much more sustainable.
Sure, sure. Interesting. So every roundtable talk, we ask our guests this question: what are you looking forward to as you age?
Oh, well, I mean, I am looking forward to an incredible, longer, different journey. I mean, my
Sure.
journey in life so far has been extremely varied. And I don't see, because knock on wood, I'm healthy. And that is the one, well, there's two things, obviously. One is health. The other is, I wouldn't call it wealth, but I call it enough resources to be comfortable. Because I have worked on, and I'm lucky enough to be able to have enough resources that I think far ahead. I'm 75 now. If I have 20 years ahead of me, that I can live that in a good way with resources and hopefully staying healthy. So I look forward to that. But having said that, I also think of life as just a series of journeys and opportunities. So um, everything is open to me. I'm a big traveler. I love seeing how other cultures live because it then helps me to understand more my own culture and the ways in which we operate here in the United States. So I look forward to a lot more travel. I look forward to ongoing learning. I just actually signed up for a new guitar class.
Oh, that's great.
You're never too old. My fingers have arthritis, and I think the best way for me to get those fingers moving is to stretch them. And so, these are the kinds of things I actually don't think of myself as doing anything very differently than I do right now. I have a pretty healthy work-life home balance. I have a life partner and two dogs and grandkids. And so they're all part of my life and will continue to be part of my life. But it's always been full, and I'm hoping that it will continue to be that. Learning for me is the most important thing. If you can learn something new every day or every week, then, that's what I'm looking forward to. New
That's great.
learning and new experiences.
That's great. And speaking of experiences. You were on the Clinton administration's task force on healthcare reform. What an honor and a privilege to be part of a team that helps to shape healthcare for the entire country. I know that was a while ago, but what can you tell us about the experience and what you accomplished as part of that team?
Sure. Well, I can tell you that I go back even further than that because I was on the Pepper Commission in 1989. That was actually one of the first groups, a bipartisan commission of very bipartisan, six congressmen, six senators from both parties focused on healthcare reform and long-term care reform. And that was really the first time that we had a large effort that looked at some type of a social insurance model for long-term care and actually looked at front end and back end coverage. All the discussions that we hear now around the future of financing long-term care, 1989, we were having many of those same discussions. Fast forward to 3 years after that, when Clinton came in and we had this huge opportunity and aspiration around major healthcare reform. And I will say a couple of things. Some people say that this was a very closed effort. To my mind, it was one of the most open efforts. We met with so many different people of all walks of life in terms of trying to figure out. In my case, we were working on long-term care reform. There were a bunch of other pieces around medical care reform. But it was an open process. And I think that although we weren't successful at getting legislation passed, and actually what we focused on with that particular activity was really trying to expand home care for everyone. And it's interesting, that was in 92. Now we're in 2024, looking again at how do we get more investment in home care so that people can actually remain in the community for as long as possible. So I think we sowed the seeds of a lot of the work that has gone hence and work that will continue to go because this is also a journey. And, we will figure out, Charles Lundblom once said, we are a muddling through society. That's what United States does. We muddle through until we get to an end. We're very incremental.
Sure.
Working with Singapore, I can tell you they're not incremental. They make a decision, they go look at different systems, and then they figure out what they want there and they put it in. But of course, it's only a 9 to 11 million nation state, right? We are a huge country, but we muddle through. And I think a lot of what we learned in the work in 92 is it was prescient and it's as present today as it was then.
Are you optimistic? Do you feel like we've made progress?
I call myself the pessimistic optimist because you couldn't continue to work in this sector if you weren't. I think we have made a tremendous progress in a number of ways. If you recall, in the old days, we had wards in nursing homes. People with any kind of cognitive impairment were tied down, literally. If you look at what has occurred in our sector, the movement towards many more options, the culture change movement that is changing the face of residential care in a way that is more akin to actually person-centeredness and home-like environments. Real discussions around the future of financing for people who do not qualify for our safety net. And so I think we have made some significant leaps. What I do also think is that it was really hard to make those leaps when we were a relatively young country. We are now catching up to Europe. I mean, Japan is already 30% over the age of 65, and they have some of the oldest people, as is South Korea. We're still relatively young, but our baby boomers have reached that 65 and over, and we're starting to see the 85 and over population grow, which is when the crunch for long-term care is really there. So I think that the value of what was done before sets the stage for what can be done now. I would tell you, I don't think there's a whole lot of new ideas on the face of the earth here, because there are only a number of ways in which you can solve some of these things. But we have the addition of technology. We have the addition of AI that helps us make decisions quicker. And so I am optimistic that, again, with our incremental way of doing things, that we will get to solutions that will make long-term care easier for people to figure out, more affordable for a larger swath of the population, with more options that are going to fit people's needs and preferences.
That's great. That's great. Now, getting back to the federal government, what role could or should the federal government play in supporting, accessible long-term services and support for older adults?
Yeah, I believe I'm a strong supporter of a social insurance model of financing. I mean, I don't know, I think we look at different administrations, and we're certainly not at a period, I think, right now where there is a lot of possibilities of entertaining the notion of some type of social insurance model. But if you look at different countries, Europe, Asia, almost all of these countries have some type of social insurance that gives everybody some access to financing. It's not full coverage for everything, but it is dollars and resources that can be used to purchase services with a safety net there as well. I believe that is the best role for the federal government, because that is where you actually spread the risk across the entire population. And the problems of relying on state-based programs is that the inequities are pretty significant there. At the same time, I believe that there's huge roles for the private sector, particularly in developing residential alternatives for low and modest income folks who need a place to live as well as to get services. And I think we need a lot more exploration. And there, the role of the federal government as well as state government could be to provide incentives, new types of tax credits, for example, ways of thinking about how we use dollars more efficiently and effectively. So creating public-private partnerships that really work and that spur the creativity and the innovation that happens in the private sector. So I think both of those things can happen simultaneously.
Gotcha. Well, that's great. So what do you see as the most pressing issues? Because we've talked about a lot of issues in our time together facing the aging services sector in the next, let's say, 10 years.
Well, workforce is certainly the biggest, I think, because unless we were to replace human beings, which I do not believe in 10 years we will be doing. I mean, I don't know. I'm not a prognosticator, but I think at least for the short, long term, we need human beings. We need qualified human beings. And some of this we can do with our own population. But if you look at the data, we're also seeing that there will probably be shortages of the folks who actually would be in the age categories to be in these jobs. And so we need pipelines. This includes immigration. As I said, between 25 and 30% of this workforce right now are immigrants. That doesn't mean they're all, some of them are naturalized citizens. Most are legal. We do not know, quite honestly, we don't have an accurate count of undocumented people working in this sector, but we know they are there. But immigration policy is going to be critical around thinking about how do we right size this workforce for a growing older adult population that is going to be happening over the next 20 years. And by the way, the baby boomers are a huge group, but the millennials are a huge group too. And they're coming up again. So policy cannot be thought of in a static way, but it has to be thought of across generations. And I think workforce is going to continue to be a serious challenge. The second is affordability. I mean, if you don't have resources to purchase, then it's a challenge. And we also are seeing somewhat of a decline in family caregivers. This is a demographic phenomenon, not family caregivers not doing the work, because the percentage of caregiving is exactly the same as the first study that I did in 1982.
Interesting.
That is 80 to 95% of all services are provided by family members. So we talk about the formal sector, right? We haven't calculated what goes into family caregiving. That's all unpaid.
Sure.
That's going to continue, but the proportion of those folks is going to shrink somewhat for a number of demographic reasons. So we're going to need more of a formal workforce, and we're going to need to have more options for where people can live and receive services. So I think that's the other biggie: workforce and affordability of options. That's what I see sort of looming. And then the third uncertainty is really the role of technology. I mean, I'm sort of a Luddite, but I actually embrace technology. I just feel like we haven't been in this sector, we haven't been incredibly thoughtful in terms of how we intentionally use technology to mitigate some of these challenges.
Sure. Now, you reference how, we've talked about other cultures, we've talked about, what's happening in Japan with the aging population, et cetera, and some of the payer models and such. Every culture has its own unique way of valuing and supporting older adults, at least seemingly so. Based on your experience, are there aspects of how other cultures approach aging that you wish we could adopt here? Recognizing that, as you referenced in Singapore, it's a radically different, population size. So therefore, it's easier to implement in a smaller organization or smaller country.
Great.
But what do you wish we could adopt here?
Well, I do think a more planful approach, and why I've done work in Singapore for years, and what was always interesting to me is that in 1959, when the country was established, and in those days, that little tip of Malaysia was the poorest part of that part of the world. It's now one of the wealthiest parts. But the founder basically said that the first principle for this whole country was that everybody has a home. And so the way that Singapore was built mostly high up and in flats, but most of these folks own their own flats. They all have a place to live, and they are built around communities so that they have the natural infrastructure for actually aging in place. And, we don't have a lot of that. In some places we have it because it's become intentional, but we have such disparate geographic areas. One of the things that I really worry about, for example, is what do we do in rural communities? And this has been an endless challenge, because when most of the younger people move out, and you're overrepresented with older adults in rural communities, and yet you've got challenges of lack of resources, long distances, all of those kinds of things, large land masses, but they're not being used. People own their own home and land. How do they turn that into something that can actually invest in some type of a community infrastructure? So I think we could learn from some of these other places like Singapore, like the Nordic countries, Denmark, that have done these intentional communities where they're integrated into they're not sending off older adults to another place. They're integrated into the community. And we always say we can't learn from them because we're not exactly like them. Well, in some places we are. We have very densely populated areas, but even where we're not, there's still attributes that we can learn from that. The other is that we created I know Biden talked yesterday about the tech industrial complex. We created a medical industrial complex and a long-term care industrial complex in 1965, when Wilbur Mills introduced Medicaid as a program that would, in addition to covering healthcare, would cover nursing homes for low-income older adults. And so it was established the modern nursing home. I think we have a lot to learn from cultures that don't have that infrastructure in place and have a stronger home and community-based informal network, but also community network. And, what can we do to think about not just bricks and mortar, but how do we actually think about community and bringing services together for community? And that, I think, is why we need to look at the ways that different cultures do things.
Sure. Hearing you talk about that, do you think the village movement has tapped into something there?
I think the village movement has. I've been, again, pessimistically optimistic for two reasons. One is, for a long time, I thought of it as pretty much a concierge model for high income, and maybe upper middle class folks, mostly white, and mostly focusing more on concierge types of services like, book clubs and museum trips and those kinds of things, although also supportive services like grocery shopping and those kinds of things. But I think more and more the villages are recognizing that their populations are aging and that there are more intensive needs. And so there's a lot of partnering that's going on with community-based organizations within the village movement, as well as focus on things like partnering with affordable senior housing properties that may be near a village or even within a village, so that they're bringing more lower income populations into the mix. And I do think the principle of the village is a wonderful one. So yes, it has some of the pillars of what I think you would need. It just needs to fill in the flesh a little bit. And by the way, they also are becoming a lot more electronically connected and using data, which I think is one of the things that's really going to help us. I'm a strong believer in population health oriented activity. I come out of public health, and I believe that that's the way that we should be organizing our services and supports. And the village is sort of a movement that's in that direction.
Sure, sure. Now, are there any common misperceptions about aging that you wish more people understood?
Well, I'm going to say something, and I know this is a podcast, and so people will hear it, but one of the things that I was really upset about when I saw a lot of the attacks on President Biden, and I don't think even that the advocacy organizations have done a very good job. There was so much ageism in not implicit, it was overt, calling him senile. Even journalists that I thought had more knowledge than they did, just using these old words that aren't even appropriate anymore. I wish that people understood the difference between aging related types of diseases and things that occur but are not necessarily related to age itself. So it gets conflated. And so I think we still have this view of aging as completely negative, downward trajectories, and don't have as much of a vision of the wisdom and the opportunities that we have as we age and become older. And to me, this fundamental ageism just pops up all the time. And I really hated the way that was dealt with, because I think it missed an opportunity to actually teach people about a person who is aging, who may have some health problems, but disentangling that from age, and
Great point.
and how the mind works and how all people do all of these kinds of things, even in the face of maybe physical challenges or even cognitive challenges. So, I believe that was a missed opportunity. And I always think we're making inroads. And then, of course, I see the anti-aging ads on TV, and I'm like, I don't know, did we really make many inroads? So, on the other hand, I think these blue zone foci are also somewhat idiosyncratic. And so we're either looking for the blue zone where everybody lives until 120 healthy and then just drops dead, or we're looking at decrepit, demented, I put that in quotes, people, and death. I call it the 3Ds. And it's really neither of those. It's the whole wide spectrum in between.
Sure, sure. No, that's a great point. Now, you've been very generous with your time. Thank you for that. But before we wrap up, I'd like to have a little fun, if we can shift, with something that I call game changer or gimmick. I'll name 6 innovations in senior services and aging services, and would like to have you tell me if you think it's a game changer or a gimmick. Ready? Robotic caregivers. Game
Gimmick,
changer or gimmick? Gimmick?
gimmick now.
Okay. Why do you say that?
Because I don't know what the potential of artificial intelligence really is
Okay.
in terms of, there's something innate about caregiving, and there is the emotional, spiritual, soul part of caregiving that is really, really, really critical. And I haven't seen it captured. It doesn't mean that it couldn't be.
Great point.
But that's why I say I'm putting it within the context of today.
Sure.
Today, I think it's a gimmick.
Virtual reality for older adults.
Changer.
Okay. Okay. Why?
Because I think for many folks, and it's not for everyone, but it allows people to have experiences that are way beyond their ken, way beyond their resources, and opportunities again to grow and learn and expand. And it breaks those boundaries because you're no longer constrained physically.
That's great. Multi-generational housing communities. Game changer or gimmick?
That's so hard because I just helped with a blueprint on multi-generational housing. Jeez. I hate to. Is there any way to go between a gimmick and a game changer?
No, we can make up the rules. Yes, if you want to have a midpoint.
I don't think of it as a gimmick, but I think of it as an option for people who choose to live that way. I do not think it. I believe that it needs to remain an option as opposed to something that becomes normative throughout.
Okay, that's fair. AI predictive analytics for aging services.
Game changer. Again, I'd say gimmick now because it isn't anywhere near being used at all. So when we talk about it at this point, I mean, where I find it fascinating is where it's being used in diagnoses of disease. I just was listening to something, looking at something yesterday around how it's being used in radiology. The precision of being able to pick up things that the eye of the radiologist could never see. That's unbelievable.
Mm-hmm.
And that hasn't penetrated aging services, but it is possible, certainly. So gimmick means, I do think there are some things that are really gimmicks. I don't feel like it's gimmick. I just feel like it isn't really prime time yet.
Yep.
And so
Not
people
fully realized.
I would say it's more hyped
Okay.
than gimmick, but I think the potential is there.
Sure. Next one, self-driving cars for aging populations.
Could be a game changer.
It's definitely going to be interesting to see where that goes.
I could use it. I'm a horrible driver. But I wouldn't want to be in a self-driving car right now.
Do you think the world's not ready for it, or at least the technology isn't ready for it?
I don't think the technology, I don't know enough about it. It's not my sphere of knowledge, but everything that I've seen in terms of how far we are in terms of safety, and that worries me. But we will probably get to the point where that will work. And I do think if that works, that I do believe that many older people should not be on the road. And if it's possible to actually have that where those two, one of the worst situations in the world is taking the keys away from an older adult. Talk about disempowerment.
Dramatic.
So if this could work, bring those two things together, keep the individual empowered, able to get around, and also not worry about the safety issues, I'm all for it.
Well said. That's great. Last one, telehealth as a substitute for in-person care.
Oh boy. Well, again, the gimmick versus the game changer. I've been part of a telehealth effort, and to set standards for, particularly for home care visits. This is really around working with geriatric home care docs and folks who use telehealth to actually do virtual visits and work with clients who are homebound or who have a lot of trouble getting out, and in rural communities too. But we've also seen quite a few videos now of real experiences and the challenges that telehealth has actually brought in terms of just basic knowledge, use of technology among older adults. They're wanting to have a hands-on relationship, but at the same time, being able to have the safety and the comfort of having a connection through a telehealth visit. So I would say it's mixed. I think it has the potential to be a game changer. But at this point, I don't think it's there yet. And I do think there's probably gimmicks in it. But I think well-intentioned folks are not trying just to create a gimmick, but are actually trying to create something that is going to actually work and meet the needs of folks who really need it.
Great point. Great point. Well, last question. What have you learned that you wish you could have told your younger self? What have you learned?
I have learned that change takes a long time, and that it is more of a journey than a destination. And I think that I am one of those folks who came in starry-eyed, particularly going into the federal government as a mid-level career person in the early 70s, filled with hopes and dreams around making the world a better place. And I've learned that there's two things. One is that change takes a very long time, and it's really a journey and not a destination. But also to keep your eye on the prize. And I know it's been used by others, but I tell my junior staff this all the time, because you can get incredibly distracted and also very despairing in some of our worlds when we're trying to make change around policy or practice, and we're incremental here in this country. So you put all of those things together, and if you don't keep your eye on the prize and recognize that change, that's the beauty of getting older, is that you have I have 50 years of being able to look at stuff, right? And you just don't have that when you start out.
Absolutely.
So,
That's
yes,
really, those are wise words.
That's really the message. And on my best days, that's what I keep in front of me, that it's a journey and not a destination, because I think that's really critical.
I love that. Well, Dr. Stone, thank you so much. As always, it's a pleasure to visit with you. Thank you for sharing your insights, and we'd love to have you back at some point in the future to share additional thoughts. But
fantastic. I loved it. Happy to be with you, and look forward to more.
Excellent. Thank you. And thanks also to everybody listening, and hope you'll join us on the next edition of Roundtable Talk. Also, thanks to Dave Schaffner, our producer, and Matt Campbell, our engineer. Have a great day.